This is a KETV News Watch 7 breaking news update.
Hey, good afternoon, everybody. We are following breaking news of national import in Omaha at this hour.
We are live at the Nebraska Medical Center. Doctors are holding a news conference to discuss an American doctor with the Ebola virus coming to the Nebraska Medical Center. This is Taylor Wilson with the Med Center. Let's listen in.
Jenny will also be available here for a couple days to speak as well. So, come to me and we'll be able to help you out the best that we can, considering the load of requests we'll be receiving. With that, I'd like to turn things over to Dr. Jeffrey P. Gold, Chancellor of the University of Nebraska Medical Center, for formal introductions.
Well, thank you very much, and I'd like to extend a very warm welcome to all of you to the Nebraska Medical Center campus. I will, in a few minutes, turn the program over to our experts here who are in front of the room. But I would like to start off by telling you that approximately 48 hours ago, we were contacted by the United States Department of Health and asked if we would participate in the care of an American physician who was diagnosed with Ebola. As a result of a series of lengthy discussions with the United States Department of State, with the Nebraska Department of Health, with the Douglas County Department of Health, with the Centers for Disease Control and Prevention, with the faculty and staff at Emory University, and many other individuals, I can tell you that that patient is en route to the Nebraska Medical Center and will hopefully arrive tomorrow morning. The biocontainment unit at the Nebraska Medical Center is one of 4 in the United States. It's actually the largest. It has a phenomenal staff of physicians and other health professionals who deliver world-class care to patients needing it. This is completely consistent with the mission of the Nebraska Medical Center. We have been preparing for this type of event for a very long time. This is not a surprise that we're being called to serve in this way, in that the biocontainment units of the United States were prepared specifically to deal with this type of disease. It should be well known to all of the audiences that not only will this patient receive world-class care, but all of our patients, students, faculty, and staff will be completely protected and safe during this entire episode of care. At this time, it is my pleasure to introduce to you Dr. Phil Smith, the director of the Biocontainment Unit. Dr. Smith will introduce his colleagues seated to his left and to his right. We are also very, very pleased to have with us this afternoon the leadership from Douglas County Health Department and the Nebraska Department of Health, who will also be available to answer questions and to participate in the discussion as this goes further. So with no further ado, it's my pleasure. Dr. Smith, it's all yours.
Thank you, Chancellor Gold. As Chancellor Gold mentioned, the Nebraska Biocontainment Unit is preparing to accept, at the request of the Department of State, an individual with Ebola who was on a mission in Africa and acquired this very serious viral disease. This is not about a single institution. This is about collaboration and about partnerships. Dr. Joseph Cerno, Chief Medical Officer for the State Nebraska Department of Health, is very much a partner in this. If it weren't for the State Department of Health, we wouldn't have a unit. We collaborated with the building of it in 2005. We collaborated since then, and jointly it was opened by the two of us when we were visited by the State Department. Also, I'd like to acknowledge Dr. Adi Poor of the Health Department, Douglas County Health Department. We feel that the university, the Nebraska Medical Center, which is the hospital, and public health are partners very much in taking on an obligation of this sort. The biocontainment unit is built for this sort of events. It was inspired by the SARS outbreak of 2003, where a number of healthcare providers became very ill and some of them died, in Canada in particular. And since that time, there have been a number of illnesses like avian flu and monkeypox that have posed a potential threat. The idea was that we could give this person first-class care in an environment that provides for optimal safety. So we have a special unit with special airflow and pass-through autoclaves and a number of mechanical features, but our most important feature really is our staff. We have a very specifically trained staff of 30 to 35 people. We actually have had a number of individuals volunteer to join our staff since Ebola became an epidemic agent in Africa. And our group inspires me. Working with them on a daily basis is remarkable. And they're one of the main reasons why we feel we're able to provide care in a safe environment. Because I'd ask my co-director, Angela Hewlett, to talk a little bit about Ebola virus and the treatment or lack thereof.
So as you know, there's an ongoing outbreak of Ebola virus in Africa. Several countries in Africa have been affected. So far, we have had 2 individuals being treated in the United States that were highly publicized and taken to Emory University. This will be the 3rd individual that will come to the United States for treatment. The virus itself is, this is a scary virus, but I do want to emphasize that this is a virus that is transmitted by direct contact, so contact with infected secretions, blood, bodily fluids, that sort of thing. This, unlike SARS, avian influenza, and other viruses of that nature, is not an airborne virus. Our personal protective equipment in the Nebraska Biocontainment Unit is geared for this virus, as it would be for SARS or avian influenza as well. The outbreak itself is escalating in Africa. As you know, it has affected several countries now. And, this is of concern. We have a lot of people over in Africa, physicians who have gone over to volunteer to take care of patients over there. And because of that, there was a high likelihood that one of these people or several would become infected. Again, the virus itself, there were some investigational products being used that you may be familiar with. One is the ZMapp product, which is a monoclonal antibody that was given to the 2 individuals who arrived at Emory University. This product is no longer available. There is none of this left to use. However, there are some additional products that we are looking into. But the tough nature of this disease is just the fact that there isn't any notable therapy other than good supportive care, which we're prepared to provide at the Nebraska Medical Center.
Thank you. I'd like to ask Mark Rupp, epidemiologist at the Medical Center, to make a few comments.
Thank you, Dr. Smith. I serve as the medical director of our Department of Infection Control at the Nebraska Medical Center, and I am very confident that we can care for this patient safely. As Dr. Smith related, this is a specially designed unit. It's locked, it's secured, it's separated physically. It has negative air pressure, HEPA filtration of the air. It's not recirculated air. There's an autoclave on the unit, so all medical waste materials will be autoclaved before they're removed from the unit. The team that's led by Dr. Smith has drilled for this for years. They are well prepared, and I'm very confident that we'll care for this patient appropriately. I think there will be a number of folks who will ask, why are we bringing somebody here to the United States, to the Nebraska Medical Center with Ebola virus infection? And then my answer to them would be, this is part of our mission. Obviously, these healthcare providers were on a mission in Africa, and our mission is to care for patients, and we're going to do that, and we're going to do that safely and as effectively as possible. In addition, as an academic medical center, part of our mission is to push back the boundaries of our knowledge, and we're going to try to do that as well. We will be looking at these agents, as Dr. Hewlett has mentioned, and we'll be learning as much as we can in order to help patients in the future. Thank you.
If anyone has any questions, you can certainly field those now.
I'm Marjorie Beck with the Associated Press. Can you tell me, do you have any idea what time
Well, I'm not sure, and that I think we have a team that's coordinating their arrival, and I think that in order to keep it straightforward and minimize the disruption to the family and the patient, that's not being publicly released.
Do you have an idea of what conditions you're looking at?
That's a good question. We have just sort of short, brief reports from the team on the ground in Liberia that he is in reasonably stable shape. He's had a number of complications of his disease, but apparently he was able to get on the plane under his own power.
Aaron Murray with Channel 6, can you explain once he gets here what you guys will go through and how that whole process will work with getting him into care?
Do you want to handle that?
Sure. So once the patient arrives, they will be transported to our unit, and once in the unit, then we will provide the supportive care necessary depending on our initial assessment of the patient, and again, based on his needs. And that's not something that we'll really know until we are able to see the patient and assess what type of care he needs. And from there, we will again provide aggressive supportive care to him as is indicated for this disease. In the realm of our biocontainment unit.
Dr. Hewitt, Jeremy Maxwell from KETV. When we toured the facility in August, staff mentioned that there were 30 staff that volunteered. You had mentioned that there were more since the Ebola outbreak. Are all 30 plus being activated right now, or is a more select team going to be treating this individual?
All of the individuals have been activated, and then we will be caring for the individual based on routine medical care with shift work and that sort of thing. So yes, all the individuals that have volunteered to take care of patients in the unit have been activated at this point.
And how many staff members will be there with the patient on a 24/7 basis? I know some of that is depending on how he's doing.
Exactly. So some of that will definitely depend on how he's doing. There will be several staff members there at all times taking care of the patient, several multidisciplinary staff members, nurses, respiratory therapists, care techs, and physicians.
But the total number in the suite at any one time caring for these patients is approximately 5.
Right.
We obviously need more than the minimum because taking care of a patient wearing heavy protective gear is somewhat tiring.
Going back to the intake, we saw helicopter images of the patient going into Emory University on his own volition in a self-containment unit, leaving the ambulance, knowing that the biocontainment unit is on the 7th floor, I believe, of University Tower here. Will it look the same tomorrow morning when we see that patient come here?
Well, we have several. Dr. John Lowe and Dr. Sean Gibbs of the College of Public Health are specialists in environmental decontamination, and they've been working with a number of other groups to try to make sure that all the preparations are in place and all the adequate cleanup and disinfection take place. It's a very complicated procedure, and it's one that we have practiced and rehearsed many times.
Dr. Lindsay Dees with KMTV, Channel 3 here in Omaha. Can you talk specifically about some of the training and procedures that the staff members have to go through if you were to learn about this?
Yeah, they go through quite a bit of specialized training. They range from lectures about bioterrorism agents that they might get to see, or what we call emerging infectious diseases. So we teach them about avian influenza because that's still a disease of interest in the Far East. Teach them about Ebola viruses, which is what everybody's focused on right now, but a number of other agents that have been prevalent or they're likely to encounter because of travel. They go through special training and protective gear, putting it on, taking it off, and they're all paired up with someone. We don't have someone doing this alone. They're partners to kind of keep an eye on them and try to make sure they do it the right way. We do a lot of drilling. So, and I'm going to compliment our Shelley Sweethelm, our lead, who works through these people, and there'll be a simulated patient with smallpox, let's say, and we'll go through a drill with Offutt Air Force Base where the person is brought up in an ambulance and dealt with, picked up, taken up to the unit. People put on their special garb. They activate the special aspects of the unit. So they range from lectures to a full-scale exercise.
How many drills have you done for Ebola specifically?
Well, we do quarterly drills on a variety of topics, and we've talked about the general category of diseases called viral hemorrhagic fevers that Ebola is one of. We sort of thought that the reason we have thought about that in the past is because that's one of the more dangerous agents that we would work with. So we are somewhat familiar with it. And obviously, when we could see this outbreak spiraling out of control in Africa with all the people that travel, you probably have read about the 68 false alarms, people who came from West Africa and showed up in a U.S. ER. I think it's not unlikely that we might end up facing a situation like that somewhere in the U.S. where a person with Ebola just shows up in the emergency room because of travel.
So it's 4 times a year since 2005?
Yes.
Okay.
Doctor, what Ebola treatments consist of? What, breathing treatments or IV treatment? What sort of things will the patient be getting?
Well, some of the things we do, things we do for any patient. In other words, routine care, what it consists of checking their fluid balance, checking their blood counts, giving them fluids IV, giving them food, giving them medications, checking their blood pressure. And then we do have a capability within the unit of bringing in special equipment, such as a ventilator, if the patient needs that. As Dr. Hewlett mentioned, we do not want to take the patient out of the unit. That would defeat the purpose. But there are quite a few ways of providing treatment at a fairly intensive level in the specialized unit.
Dr. Smith, Paul Gutierrez, Fox 42. When the general public hears something about this, that an Ebola patient will be coming right here to Omaha, Nebraska, they may feel a little uneasy. What reassurances can you give the general public that this is all going to be okay?
If you don't mind, I defer that to our colleagues in public health.
Thank you. And we know, even with all the preparation that is going on, safety of this community is always my #1 priority. And therefore, what the Douglas County Health Department is going to do is we are going to do an Ebola information line for the general public. So the general public can call in and ask questions about the disease, and we'll try to therefore alleviate some of the anxiety that we probably can find in our general population. We also have put information on our Douglas County Health Department website, douglascountyhealth.com, and the cdc.gov website has a lot of information for general purposes. So we hope that with all this around us, that we can alleviate some of the nervousness that the general public has. And Dr. Asurno.
Sure. Thank you very much. Thank you to the Medical Center and to Dr. Poor. I'd like to reiterate all of what you've heard today is a reason why, from the state's perspective, we believe that the risk is minimal and there is not a reason for people to be fearful of what's going on. If you look at it, we have the opportunity to help a patient here specifically, and so we look at that opportunity. We also look at how the facility, what has been put together over the years. We evaluate the risk. Look at that as there is minimal risk. We look at the staff themselves. And then we look at the general public as well. So we're looking broadly throughout the state of Nebraska and within the region of the state of Nebraska. And we think, considering the way the facility has been designed, considering the expertise we have with that facility, considering our partners, we believe any risk is minimal, and we think there shouldn't be fear, but we understand there will be fear. We stand ready to answer those questions, and with our partners, I think we'll be able to answer the questions as they come about.
And just to further up on that, as has already been stated, this virus is not spread through casual contact. It's not spread via an airborne route. It's spread by close contact with blood and body fluids. We are very prepared to deal with this patient, and this poses an extremely small risk to any other patient or the general public.
And doctors, a follow-up on that, to demonstrate how you further minimize that risk, can you talk about the specific steps the caregivers involved will take when they come in and leave the facility, and also what ongoing monitoring, self-monitoring they may undergo during the treatment?
Go ahead.
Okay, well, we, as Dr. Smith mentioned, we have a very specialized staff. We also have a lot of protocols in place to protect the safety of our staff members. Part of those protocols involve our personal protective equipment, as we mentioned, which is very sophisticated and is geared specifically toward this disease. This is also based somewhat on the Emory experience, and we have discussed this with our colleagues at Emory University and to determine the most appropriate equipment that we should wear to protect our healthcare workers. The healthcare workers will, as someone mentioned earlier, have a partner involved when they put on and take off this personal protective equipment to ensure that it is done in a very meticulous manner and that there aren't any breaks or any concerns with the, we call it the donning and doffing of personal protective equipment. They will also shower out when they leave the unit. We have a decon shower as well as a hygienic shower, and so everyone will shower out on the way out. We have a lot of protocols in place, and these have been very well thought out, drilled previously, and again are sort of to provide optimal protection for our healthcare workers.
And for people without the technical understanding, if you can kind of boil it down for us, what are some of the specific equipment recommendations that maybe you've learned from the team at Emory after they treated those two patients there?
So mainly with personal protective equipment, what we want to do is, and this is geared specifically towards a viral hemorrhagic fever that is transmitted via contact. We have several different types of personal protective equipment that also will be determined based on the patient himself and what type of symptoms he's having, what type of secretions we're concerned about, and that sort of thing. We also are able to scale up or down based on that scenario. Usually this involves the use of a gown, a full coverage gown, booties that actually cover your feet and part of your leg as well, several layers of gloves, a mask for respiratory protection, as well as a full face shield. And so that way we don't have anything exposed. Again, this is a contact disease. What we're concerned about is our body secretions, and so we're looking to protect ourselves via the contact route. So that's what we're going to do.
We actually learned a bit from Emory experience. They probably saw pictures at the beginning of the outbreak when they had the full outfits, the yellow one-piece Tyvek suits that zipped up to the neck with a hood, and then a PAPR, which is a positive air purifying respirator that has a fan on it. Fits over your head. It's got on your belt you have a battery pack, and it blows air continuously inside of your mask, so the air is coming out, minimize the chance of any back current. But they found that after they took care of these patients for a little while, that they weren't comfortable backing down to the level of protection that Dr. Hewlett's talking about. And I want to add that even though it's backing down, it's still 2 or 3 layers of gloves instead of one. It's no comparison to what you do on an ordinary hospital floor.
Can you talk about your conversations? Are they ongoing still with the doctors and staff at Emory?
Yes, we've had multiple conversations. All 3 of us have multiple conversations with the staff at Emory, the infectious disease physicians, Dr. Bruce Ribner, and some of his colleagues. We've also had ongoing conversations with the CDC and a number of other individuals, including some in the military, who've had some experience at dealing with hazardous infectious diseases. So even before we had any idea that we were going to be selected, we were exchanging information just as part of our general preparedness.
Doctors, can you talk a little bit about this patient, what he was doing when he contracted this virus, and how he's doing now?
As far as what he's doing now, he's sick. We don't know the details. And he's got a long plane ride to get here, so we don't know how that will change before he gets here. We do not have any specific knowledge of what breaks in technique, or if there was a break in technique that led to his getting infected. And we really don't know for the 2 down in Atlanta either.
Just to confirm, we are talking about Dr. Rick Sack.
I can't answer that because of patient confidentiality. So
Doctor Shubert from KIOS. Is it possible that Nebraska Med will receive additional Americans with Ebola in the event that more Americans working in West Africa should?
Well, I think that's a very good question, and the answer is I don't know. The reason, one of the questions that people ask is why did the State Department put the first 2 people at Emory and then bring the 3rd one here? And I think with the answer when we asked them that was we visited your unit. We visited every unit in the country that had this capability. We liked your unit. We thought you could do a good job. And based on the trajectory of the epidemic with over 3,000 cases and many fatalities and the international travel and all the Americans that are over there working in less than ideal conditions, it seemed likely that either by someone getting infected over there, being expatriated back here, or as I mentioned, a traveler that might get off an airplane, it seemed likely that we're going to continue to see people like this. And so they want to test the capacity of different places and have more than one facility, namely Emory, on call and able to handle a patient like this.
Will the same plane that brought over the other 2 patients bring this patient to Omaha?
I don't know if it's the same plane. I can't answer that.
You mentioned that long flight possibly affecting this patient. Can you go into a little bit more detail about that, please?
No, I just meant to fly from Liberia to here is a very long flight, and while there is going to be some general support available on the plane, it's not going to be like being in a full hospital. Of course, where the patient has been up till now is not being like in a U.S. hospital either. So I'm sure he'll be glad to arrive.
Obviously, this patient has a family and loved ones that are caring about him. What kind of ways will he be able to communicate with them while here?
Well, we do not allow visitors per se. That's our policy because, again, that would sort of defeat the purpose. We do have a very good system of two-way video cameras. So, and we have rooms nearby that family and relatives, and we also use those for consultants. So, for instance, if we might have the patient develops a rash, a dermatologist maybe instead of gowning up and going in the room can look at the video camera and say, oh, I think it's a drug reaction. So we're going to, we also, it's not just the matter of showing them pictures of their loved one, having two-way conversations, which is important, but we're trying to attend to some of the social needs of this family while they're here. I know they've been through a great deal.
On that. You mentioned additional products that we would need. Can you describe those products?
Well, there's there are several products. One is called convalescent serum. It's when you take blood from a person who has recovered from the illness and so presumably has antibodies, and either you just give the plasma or you try to concentrate it and give that back to the patient. So a patient may have serious illness, and before they can develop enough antibodies on their own to protect themselves, they may die. This way you're giving them some antibodies. That has not been studied very extensively. There are two other products that have been used primarily in monkeys. They have some theoretical basis as antivirals of interest, but the experience is extremely limited, and the knowledge of toxicity is limited. So I think we've been trying to collect as much information as we can about these, talk to the different experts at the CDC and at Emory and other places where they've looked at them, and we'll sit down and talk to the patient and try to look at the risks and benefits and whether we think it'll help and whether it's safe.
Is there a possibility that you're looking at this serum that one from the previous two aid workers who've seen recovery?
Well, that depends on a number of things. We've run into some obstacles in blood typing, and so it's not always easy. And I don't know about the willingness of the other people to donate. They probably would, but we don't know that for sure. As I mentioned, it's all very preliminary. Most experts agree that ZMapp, which Dr. Hewlett mentioned, was by far the best treatment. And unfortunately, that's not available. That's gone. They're going to make some more, but right at this particular time, that's not available.
How long does that take?
From what I understand, I'm not an expert in this area, 1 to 2 months before they get enough that they could treat another patient.
I understand that not knowing much about the patient's conditions as he's in midair right now, that's tough to answer, but do you have any idea of how long you may be activated with this patient in particular?
I know that Emory, the patients were at their hospital for several weeks, and we anticipate that may be the case, but again, we don't know for sure.
And I apologize if this was already covered in some of the logistics. Can you describe, will one of you be there at the tarmac when this plane lands tomorrow with the patient, and at what location will that plane land?
Again, we're not really disclosing that just because we want it to be as uncrowded and as efficient as possible. But just suffice it to say, the team that I mentioned before has done an extraordinary amount of work and practice, and you can be assured that the transfer will be smooth and not pose any infectious threat to any area that they're driving through.